You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. Today's episode is part one of a two-part series that focuses on the legal implications in healthcare related to CMS and ONC rules, telehealth, information blocking, and price transparency. Our panelists today are Senior Health Information Technology Consultants Gary Austin, Ken Kleinberg, and Jocelyn Keegan. Joining our panel today is our guest, David Szabo, the National Co-Chair of the Healthcare Practice with Locke Lord LLP. David represents hospitals, integrated delivery systems, physician organizations, home care companies, and other healthcare service providers. He also represents healthcare information technology companies and health plans. I hope you enjoyed today's podcast and that you'll share your topic ideas with us by emailing us at podcast@pocp.com.
Good day, everybody, and welcome to the ongoing adventures of The Dish on Health IT. I'm your host, Gary Austin, affectionately known as Lumpy. We at Point of Care Partners are health IT consultants with 100-plus associates in over 35 states. We work across all stakeholder groups, payers, healthcare delivery, pharma, health IT vendors, and government agencies, and we're viewed as an independent, trusted party, the Switzerland of consultancy. This legal podcast will be separated into two parts, and this was part one you'll be listening to. Part two will be released at our next edition. With me on The Dish on Health IT are my two co-hosts, the lovely and talented Jocelyn Keegan from Boston and the talented Ken Kleinberg from upstate New York. This episode will focus on some hot legal issues in healthcare, such as the CMS rules, telehealth, and price transparency. How about a quick hello and opening comments from our topic of the day from Jocelyn, and then Ken, and then we'll introduce our guest.
Awesome. Thanks a lot, Gary. This is Jocelyn here. I have to tell you, here at Point of Care Partners, we're actually really excited about the rules becoming finalized this week. I think that the way that things have turned out with really little delay in the actual rules themselves and just delayed enforcement from CMS and ONC, I think is something that we can be really looking forward to help maintain the momentum that we're seeing around APIs in the FHIR community. There's a myriad of content, consent, privacy issues in the new rules, as well as what it really means for liquidity that comes with patient and population-specific data exchange with tools like FHIR. And as we really unfurl sort of the world of APIs into our ecosystem, I'm really looking forward to today's discussion and what Ken and our guest have to say.
And Ken?
Folks, Ken here. I was thinking that with these ONC and CMS rules being finalized, it's more than just the horses out of the barn. I mean, the government is riding this horse, and they're going to be hunting down the bad guys, and it's really going to be the Wild West for competition again. But the question is, and I'm very excited about having our guest on today, is how big a spurs does the government have here?
Excellent way to look at it. Thank you, Cowboy Ken. So, in addition to the Dish on Health IT gang, today we have an esteemed guest, David Szabo, leading healthcare attorney with Locke Lord, based in Boston. Dave is a national subject matter expert across many different healthcare legal areas, and I personally had the great pleasure to work with him back around the turn of the century. That's this century for those of you who know both of us. In getting many of the RIO and HIE activities started up in Massachusetts. So Dave, could you introduce yourself and your firm so our listeners can hear your soothing Southie accent and provide a bit of your background?
Yeah, I don't know that my accent is very Southie, Gary, but thank you for the kind introduction. Gary and I did work together, I think, at making dinosaurs interoperable or something like that. But I am the pleasure of being the national co-chair for the healthcare practice at Locke Lord. And we've got, I think one of the things that makes us a little unusual is that we have a big footprint both in working with payers and providers, not just one side of the street or the other. My own practice includes transactional work, a lot of regulatory work, and a big chunk started out with HIPAA, the transaction standards, privacy, security, data breach response, and everything else that goes along with that, including helping our clients set up EMRs and affiliated EMRs for hospitals, IPAs, and the like. So it's been an interesting ride, and now with these regulations, we are opening a new chapter where, as I think was just said, the government's really pushing it now. From one of my presentations, I say interoperability, it used to be a feature, now it's a legal requirement. So I think we're in for some interesting things, Gary.
Very good. Excellent, David. Thank you. And I'll just put in a little plug here. I don't normally do this, but I've known David for probably pushing 20 years now, I guess. And his firms along the way, as they've been acquired and merged and things like that. And for anybody who needs healthcare attorneys, these guys are absolutely top notch in the country here. So I highly recommend you reach out to them if you need any assistance.
Thank you. Your check's in the mail.
Thank you. 28 cents per viewer. That's what I get. So now let's get on with our discussion. So there's a number of really hot topics going on around the healthcare legal field. Dave and I did a little pre-work this week and kind of chatted about some of them and whatnot. And we've narrowed it down to 5 topics to talk about today. So we'll kind of go through those, give ourselves about 4 or 5 minutes probably per topic area and whatnot. And the topics we're going to focus around are, first of all, compliance with the CMS O&C rules, kind of falls in the gotta do it category. Information blocking, our feeling is that the end is near, or is it? Telehealth, and will it survive post-COVID? What will it look like? And the legal issues around that. Price transparency, a really hot topic that's coming on the scene with a great amount of gusto right now. Consumers want it, payers fear it, perhaps the providers even fear it. And what does it do to pricing around the healthcare world? And we'll wrap up with some comments around data privacy in a post-HIPAA world, as it were, especially as it relates to consumer digital apps and whatnot. So Dave, let's start out with just first sort of a marketplace kind of question. Are you seeing more or less healthcare legal activity during this COVID pandemic?
Well, Gary, I think initially, as this unfolded and we had the various emergency orders rolling out from the federal government, from state governments, all the new regulatory guidance. It was really explosive, and it just kind of coincided with me getting kicked out of my office and told I have to work at home, don't show up at the Prudential Center. And just an explosion of legal work, including labor and employment matters for dealing with employees that what you could tell them, what you couldn't tell them, what information could you share about your employee's health status, what rules should you set up in the workplace. Of course, all the waivers from CMS, providers, setting up nursing homes and non-traditional sites, setting up hospital sites in, previously unlicensed space, all the telemedicine questions, just a host of issues. And then a lot of work right now around the whole HHS funding and grant process. We're looking at what kinds of information is the government going to disclose as a result of, the CARES Act funding process. How is that funding being allocated? A lot of my clients were hoping they would get to file grants applications with the government specifically related to COVID-19. Instead, they initially got about 6.2% of last year's Medicare revenue, appearing as if by magic in their bank accounts, with another tranche coming out, imminently. So Gary, it's just been enormous, not necessarily having to do with interoperability yet, but just a whole range of issues across the board for basically every client that our firm has.
That's interesting. Has it actually gotten so crazy that you've had to do things like do your own copying now at home and things like that?
Yeah, it's absolutely, and I'm fortunate in that my wife has always been a volunteer on a host of boards and chair of a host of boards and doing a lot of that kind of office work from home. So I get to now poach on her big Dell multifunction copier, scanner, printer equipment. I've been back to the office once, which I went in when my office was closed to pick up a bunch of reams of printer paper. So that's almost as precious as, toilet paper and paper towels right now.
Yeah,
getting the printer paper. So, so I'm a home office warrior. And although it sounds like I need to upgrade my webcam from the comments you guys have been making, but
there you go.
Yeah, that's I'm fortunate to be kind of heavily equipped for home office work.
Got it. Good to hear. So you'll be ready to go by June or July at least. So let's start with some of the recent CMS ONC interoperability rules that have hit the market now. So what are the legal impacts and risks around non-compliance for these? So let me start with Dave here, and then Ken, you may want to Ken or Jocelyn, you guys may want to throw in a little color commentary along with that also.
Yeah, I'd say fundamentally, and the whole purpose of this rule package coming out together, along with some other recent rules that just came out in the last week, this could be information blocking. If you don't do what you're supposed to do under either, the interoperable, and now the words are of course escaping me, but basically to allow patients through apps to download data from their health plan. If you don't make plan-to-plan data exchanges, if providers don't allow downloading directly to patients or the apps that they choose, and a host of other things. Number one, you could be involved in information blocking. Number two, there are some things that hospitals are supposed to do with ADT alerts, right, admission, discharge, transfer, that are now part of the Medicare conditions of participation. So if they don't do those alerts, Medicare could come in and say, hey, you're not living up to your provider agreement. Probably wouldn't throw them out of the program, but they could have escalating series of sanctions for those kinds of things. And also some of these interoperability rules, especially for providers, are also tightly coupled to the HIPAA rights of individuals, to get your records transferred, to get a copy of your own records, and that sort of thing. And HHS is starting to, through the Office of Civil Rights, is starting doing sanctions on these things. So I think the government is going to have a lot of tools in the toolbox to push on this if you don't follow up on what these regulations want.
Got it. Good. Ken or Jocelyn? Jocelyn, please.
Two thoughts I would love to get Dave's opinion on. So I was having a discussion just this morning about the differences in sort of legal construct of what information blocking is, and really that ability for a patient to specifically choose their app of choice, and then sort of what the implications are about that. Right now with HealthKit, that is happening sort of with no charge, no surcharge to the vendor, essentially, to be able to get that. But as we have more and more consumer applications that are looking for higher levels of volume, so what do you think it's going to look like about the difference between a provider or a vendor supporting sort of not just patient specific, but a population of patients information, and the ability for that vendor or provider to toll charge at a higher rate for a commercial participant versus just a consumer?
That is a really great question, because I think predominantly these rules have been aimed at an individual, right, for a provider, a patient, for a plan, an enrollee, for the individual to say, send my data here, send it there. Here's an app that I have personally authorized.
Right.
So you have to respond to my request under the threat of information blocking. I haven't thought a lot, and I don't think the rules have given a lot of guidance about folks that want to aggregate a lot of data across a population, other than it would happen because whoever controls the third-party app has done a lot of marketing and says, this app is great, I have a benefit for you, that if you use my app, it'll help you do something you want to do, manage your patient paid amounts, or allow you to make your records more portable, or find that thing that generates a lot of consumer interest, and then they could start aggregating based on consumers who have voluntarily chosen to direct the provider or the plan to do a download.
And I guess
So
that sort of in that seam is what I'm trying to figure out. Where do you think the difference is between when somebody is simply hitting an API on a patient by patient basis versus now I'm literally getting tons of API calls from a specific vendor, and my ability as a EHR or a provider org to toll charge on that? You know, what does that look like? Or do you think that we're going to end up in the court about that?
yeah, we might, because I don't think for the patient by patient, which is what the rule contemplates, right? You can't toll charge for that. Now, if somebody shows up and says, well, I have permission from, 1,000 people in Boston, to download them all. I mean, you have to authenticate all of them. And I think it's on, right, an individual by individual basis. The third-party vendor per se has no rights. It's the individual who has the rights. So we may see some, as you say, in the seams of this, or kind of, someone says, well, I've got, comes to a plan and said, I've got permission from most of your enrollees. Why don't we do this on a bulk basis? Well, the plan has an obligation to validate that. And that may be, a bit of a process to go through. It can go through one at a time. It may depend on the business relationship between the vendor and the plan. Is that a trusted relationship? We know who you are. We dealt with you before. Or is it somebody who kind of appears, out of the blue that nobody knows and said, I've got a bundle of permissions to do this? I mean, the risk of a plan or a provider being wrong in disclosing information to a third party without the right permission, I mean, that's substantial. That is a huge legal risk. And privacy officers and compliance officers will be all over that.
Yeah, but I have to add the ability for a vendor to get the so-called permissions is really a slippery slope, right? I mean, you want to download any app and start using it. You're signing some kind of agreement. You're not reading the 10 pages of fine type, and somewhere in there, it says, and we can do X on your behalf. Do you agree? And you're signing that. So I think this issue of this pseudo population aggregation is really one of the giant loopholes in the early stages of how these regs are rolling out. And there will be some bad actors, I think, that will surface about this.
I was just going to say, you're right on. And the government deals with it, and we can get to it later in the program. Basically says, well, the Federal Trade Commission could go after these people if they have deceptive, privacy policies. And I was a little disappointed to the degree to which CMS in particular kind of said, well, the plans, providers especially plans, don't worry about that. There are other agencies, other laws, it'll all work itself out. I share that concern that you just expressed.
Yeah, this, from my read on it, this almost seems to me sort of an abdication of responsibility. Like, we'll let the FTC chase this, or we'll let consumer fraud organizations chase this, or whatever. This feels to me like this could be a nightmare from a legal perspective, aside from an operational nightmare, just getting the data moved and everything else. So let me, I want to kind of go on and go a little bit further on kind of a joining topic here around data blocking. So, part of the regs have come out and they talk about data blocking and how there'll be penalties, and the $1 million of penalty type of threshold I think they threw out there just to scare people and things and whatnot. Are we thinking that they will try to make some test cases out of folks, maybe some vendors pretty early on here, pick 2 or 3 and really go after them hard to set the tone? Or do we think this will be a slap on the wrist sort of activity that, oh, you were bad, kind of don't do it again, guys? Or don't do it publicly again, or whatever else. Do you have any sense for that, David, in terms of, how real these penalties may be?
Well, I think part of the reality of it is reflected by the fact that the Office of the Inspector General, released a new regulation within the last week, around the penalty process for a variety of things. Also, penalties arising for fraud under the CARES Act or false claims under the CARES Act. But information blocking is in that package. So, I think if you talk to people in my business, we draw a distinction usually between the enforcement posture of OCR, which historically has been first consultative and educational, and only recently has become tougher, as opposed to Office of the Inspector General, where they've been tough guys for a long time. And, they like to think they're tougher than the U.S. Attorney's Office, except they can't put you in jail. So my feeling is there will be a period where the focus is predominantly educational and consultative. Say, look, these are new rules. There are some delay in terms of enforcement in here. And, we need to all get aligned, and you need to understand your new responsibilities. But OIG enforcement will be heavily driven, I think, by what they perceive as the intent of the person who violates, right? Is this a footfall because I didn't understand or I wasn't ready? Or is this somebody who's just saying, I don't take this seriously. I don't care. This is what I want to do, and I'm going to do it. The OIG has a lot of tools in the toolbox to make you uncomfortable. And remember, the $1 million potentially is per violation.
Right.
So
Good point. Fair point. So this could be a very large.
Yeah, you could have some, material significant, as lawyers like to say, a lot, penalties that could arise from this. So I anticipate it's going to be, I think I think having the OIG enforce it is a signal from Congress. And after all, they all look back, what did Congress want? Which is kind of ironic for me. You got a group of people who assembled to pass the laws. Most of them could not set the time on a VCR, but, they're setting the rules for interoperability. So, go figure.
The question, the question I had about that, with so many exceptions available for information blocking, won't most organizations find one of those or a few of those to wiggle through? And are we really looking at concern with only the most egregious cases, or will there be, the garden variety information blocking that the feds go after?
I think that at least in the commentary of the rule, the government's been pretty clear, or at least tried to give guidance about how broad or narrow they think these exceptions should be interpreted, how broadly or narrowly. And, on the main, they say, look, this is a narrow exception. There's a lot of ink spilled in the Federal Register, for example, about the patient harm. If you release the information, could it harm the individual? They have said, look, we want this proposed like HIPAA. It's not because the doctor thinks, you're too immature to get this information, or you'll be confusing if you get this information, or in my opinion, you'd be better off if you didn't know. It has to be, if you get this information, if it's released, you're going to be killed or injured or suffer bodily harm, maybe because you're very directly. So they give a lot of guidance in these rules. Now it's up to the enforcer to enforce them. So ultimately, you've got to, the question is the government on the case? But they've been pretty clear that most of these exceptions should be narrowly construed. And again, I've already published some guidance through the Federal Register about how that should be done. Now, I've read the original report on information blocking that ONC released years ago and sent to Congress and kind of kicked this off. And I do think there are complaints about information blocking that, well, I had to hire a consultant to write an interface and that's information blocking. Maybe not so much. But a lot of that stuff is going to be addressed by the fact that now we have standards. And that supposedly the standards are going to be well understood. You guys are the experts on that. I'm not. But I think that the general thrust of this is that these should be narrow exceptions.
Got it. And Jocelyn, you had a question?
Well, I think maybe to both, I think Ken and David's point, I think it's important. Part of the conversation that we've been having sort of within the Da Vinci community, within the FHIR community in general is, I think there will be opportunities for people to more narrowly define or more cautiously define sort of the risk they'd incur by sharing the information and look for sort of the exception path. But I guess I'm curious to know what folks think, because I feel like this is really going to be a period where innovators and the more forward thinking and technology savvy organizations are going to be able to navigate these tools better and this environment better and be able to outperform. So is this really, the people that are more cautious are going to be at risk of being disintermediated, if an EHR is less progressive? Is their provider organization going to go and stand up their own fire server or their own, pick another vendor to do that work for them? Or do we really think that sort of wholesale that, people are going to keep their doors closed and their APIs closed as much as possible? I'm curious to hear what you guys think, because I view it as an innovation opportunity.
I'm so glad you asked that, because I didn't want to come across as thinking that just because the rules might be a little loose or people can find a way through them doesn't mean they're always going to do something bad. I'd like to think, as you say, that some of the advanced organizations will take advantage of this opportunity.
Right. So, Dave, if you're in a market like Boston, that's a very progressive healthcare market, right? A lot of leading vendors, a lot of leading plans, a lot of leading delivery organizations and such, and kind of across your client base there. Are they seeing this as an opportunity to sort of advance the cause or even differentiate themselves?
I haven't been able to get into those kinds of discussions yet with clients. Generally speaking, I would say on the provider side, folks have generally looked at interoperability as a matter of, what do I need to do to satisfy, first of all, my physicians? What connections do they tell me they need, right, to take care of their patients? They say, I need this lab, or I need a connection to this particular hospital because that's where my patients, that's the other place they go to get care, and that's what I need to do my job. That drives a lot of the conversation so far. I think there will be folks that go on the innovation side to say, well, can this be strategic positive for me? At this moment in time, people are just worried about keeping the lights on. And, I think innovation right now is, we'll get to that, because really, you've lost half your revenue or more depending on what space you're in. And, so probably innovation is going to have to wait a little bit, but some will.
Great. Excellent. Let's move on to another topic. Let's move away from the rules and kind of data blocking and such. Let's talk a little bit about telehealth. So, this rapid uptake in telehealth, it's certainly taken the market by storm. It's certainly been confusing and operationally challenging for an awful lot of organizations out there. But I would expect there's a legal component to this also. So, Dave, are you seeing any sort of legal risks around either for delivery entities or payers, or maybe even the telehealth IT vendors themselves? What should they be aware of? And are you seeing a lot of telehealth legal activity now, or are you kind of anticipating it later or non-event?
I think in terms of immediate legal activity, it's just really been advising clients on the scope of the various waivers and orders, because we've got, this works at several layers. You've got your commercial payers who in Massachusetts have basically been ordered. You're going to cover it. You're going to pay the exact same rates you pay for an in-person visit. Don't argue about it. Don't think about it. It's just the governor issued an order through the insurance commissioner. So that's one level. Medicare obviously has loosened its requirements about sites and coverage generally across the program. Question how much of that will hold up in the long run. You've had the Federation of Medical Boards and individual states loosening the site of practice requirements. If we've got a doctor in Boston, will that doctor get in trouble for treating a patient, remotely in New Hampshire or in Minnesota or in California? Yep. A lot of that has been relaxed. CMS has recommended that it be relaxed. Of course, the VA has always been able to do that as a federal preemption. So, kind of advising clients, here are the new rules of the road. Here are the vendors that OCR has blessed for the time being. Very unusual, right, for the government to say, use this vendor or this vendor, and, we think you'll be okay. Will there be problems? Sure. There will be some security failure. It's almost inevitable. There will be folks that don't accurately document the care they've given because maybe the doctor doesn't think of it as being the same as an office visit, or for whatever reason. There could be some upcoding allegations. You coded it more extravagantly than you should have, and that sort of thing. But I think of those as kind of, what lawyers sometimes like to say, this is old wine in new bottles. These are not new problems. They just are kind of in a new wrapper. So we'll see that kind of stuff. Interesting statistic I saw today, Gary. Blue Cross Blue Shield of Mass announced that their claims for telemedicine, I think, were up 1,000%.
Yeah,
means,
I saw that number.
Right,
Crazy number.
Yeah, nice big number. And so I always like it when people just don't say, oh, we're doing a lot more, but then they say it's this many percent. Then you get more of a sense of it. I don't think it's done yet.
Yeah, but that you got to base that on what the multiplier was. If it's a small number to start, then it's easy to say that you increased it a lot.
Yeah, no, granted. But on the other hand, we already had in Massachusetts, a lot of behavioral health was already going out over the wire. So it was low, but not nothing, not like 3.
Right.
So.
Yeah, Jocelyn?
I would add, as a Massachusetts resident who's done telehealth visits since all of this started with my kids, I think that we really have a strong footprint, I think, and we've talked about this in some of our previous podcasts, of doing care remotely and getting care to the lowest cost center, as it were. And I think that giving permission and acknowledging that care is happening, I think probably also has helped driving that, right? Somebody can now bill the phone call that they had with me, whereas a month ago they couldn't bill that. And there's real care happening right there. Advanced practices were doing those calls regardless of whether they were getting compensated. Now they're actually getting paid for them. So
yeah,
and I think
agree.
that's important.
I think we'll see some tinkering with the dollars here post-COVID. Maybe it'll be 90% or 80% or something like that, but there's no going back. I mean, once you've done telehealth visits for an appropriate procedure or appropriate medical situation or as follow-up, you're never going back to going in the office. I mean, when it takes you an hour to take the T from Quincy to downtown to see somebody at Mass General, and you can do a phone call, why even have the conversation? So good. Let's kind of go past telehealth now. Actually, one last topic on this. I just wanted to just poke at a bit. So, it seems to me that this is an area that's just ripe for fraud. And so, Ken, kind of from a policy sort of standpoint or operational standpoint, do you see that happening? And David, how do you see kind of the legal issues around telehealth fraud and whatnot? So let me start with Ken first.
Yeah, I'll help tee this question up for David. When you look at fraud in healthcare, and by the way, I'm a huge proponent of telehealth, and I'm really happy, excited to see that it's taking hold finally. But there is a potential for fraud here. And when you look at fraud cases, not just necessarily in telehealth, but across the board, sometimes the amount of fraud is just jaw-dropping, where claims have been going on sometimes for years, and it was like nobody was checking. And with telehealth, maybe it's a little harder to fake this, to show that you actually had an electronic visit, but maybe not. I'd like to think that in those cases that go on for years, that eventually the bad guys get a little lazy, and we should be able to apply some AI type algorithms to identify where the type of visit and the type of diagnosis or condition just doesn't seem to quite match up, and it gives us the clue that we can go after these guys. Does that sound right to you, David?
Yeah, I think it is right, and of course, some of those tools are being used right now for quote regular encounters, regular services, visits that are non-remote. Claims edits, people looking at frequency of certain CPT codes, and I think as you have better interoperability around electronic medical records between providers and payers. There's probably going to be more fraud monitoring of comparing what's in the record, or at least in the structured data, to what's going out in the claims. We still have EOBs going out to patients, and every once in a while a Medicare patient opens up that EOB, deciphers it, and says, wait a minute, we were on a tour of Europe, when my doctor said I was, getting a laserectomy. And then, it's off to the races. So there are a lot of tools. I think, again, some of them will just be deployed a little bit differently. There may be better tools coming down the road because of electronic health records. A big problem now is just the cut and paste record. I mean, the government's on the warpath about that. When they go to and look at, visits and things, and there's 15 people that have the exact same narrative for the patient, and they say, this does not look like a contemporaneous record of what happened on this particular visit. And they're not amused by that stuff. So
right.
Do
you see a situation where the government may mandate that the EMR encounter itself, the video link of it, the recording of it, is being required to be admitted into the EMR?
It's an interesting question. I've never seen that. I think, there's probably some issues around. Let's say I'll pick on probably the most extreme case, a behavioral health visit, where you could have a lot of stuff that would probably fall normally under the theory of process notes, things that you would never ever disclose to anybody, things that you would never send on to another provider, the patient's very intimate statements and reactions about particular things that have happened in their life, that maybe if they were ever recorded would only go in a notebook that was not in the electronic health record. I can see privacy advocates and compliance officers and a lot of other people saying, that's just a colossally bad idea. Now, could you extract some information from that video to prove that, there was a remote encounter of a certain period of time, and this is the identifiable devices at both ends and some things like that? Yeah, maybe stuff like that, but I wouldn't want to see a recording of a conversation between a physician and a patient kept for review by the government.
Thanks to everybody for listening today. And this is part one of our two-part series on legal issues in healthcare IT with our esteemed attorney, David Szabo from Locke Lord.
Thank you for listening. If your organization needs help understanding the FHIR landscape and developing or updating your interoperability roadmap to reflect requirements of the recent CMS and ONC rules, reach out to us at info@pocp.com.